Hello, friends. I am Dr. Harvinder Singh. I created this website called Psychiatry Education Forum, which many of you are part of. And I'm very excited to release our first video podcast for the website and for our course. The topic for today's podcast is comparing mood stabilizers. Before we begin, let me introduce myself, about this website, and about our goals. I promise I will take a minute or two. So I'm Dr. Harvinder Singh. I am board certified psychiatrist here and actively practicing psychiatry. I love teaching, so in my free time, I post on this website, Psychiatry Education Forum. This website was created in 2011. And since then, we have published 2 books. Most recent one was Essentials of Inpatient Psychiatry. And in January of this year, we published our first online course. And our goal is to have all clinically relevant topics in psychiatry in one place, which will be our course. It's called Physician's Guide for Clinical Psychiatry. This video podcast will be available for free for our website members and for our course members. Please let me know if you like it. Okay, friends, let's begin with our discussion for today, comparing mood stabilizers. I will be comparing these 5 mood stabilizers: lithium, Depakote, carbamazepine, oxcarbazepine, and lamotrigine. To make it less complicated for listeners, I will be summarizing these 5 mood stabilizers in these 6 different sections. As you can see, these sections are FDA Indications for all, CANMET and ISBD 2018 Guidelines for all, lab work needed before initiating treatment, therapeutic level for all, drug interactions, and important clinical facts. So let's begin with our first section, which is FDA indications. We'll start with lithium. We all know that lithium is our oldest and most effective mood stabilizer, and it was introduced to psychiatry by John Cade for mania treatment in 1949. After that, many studies were done, including randomized trials, and lithium received its FDA approval in 1970. Since then, lithium is approved by FDA for same indications, which is first, acute manic episode management of bipolar disorder, and second FDA indication is for maintenance treatment for bipolar disorder with history of mania. So you can see it's primarily focused on mania treatment per FDA. Second medication, Depakote. Depakote received its FDA approval in 1995, and it's FDA indicated for acute manic episode of bipolar disorder and not indicated for any other phase of bipolar. But it does carry FDA indication for seizure disorder management and migraine prophylaxis. Third medication, carbamazepine, is FDA approved for both manic and mixed episode of bipolar disorder. And this is acute phase management only per FDA. The other indications for FDA are seizure disorder management and trigeminal neuralgia pain management. Our fourth medication, oxcarbazepine, is not approved by FDA for any phase of bipolar disorder. So most of the treatment is off-label in bipolar disorder patients. But it is FDA approved for seizure disorder management. And our last medication, lamotrigine. It's FDA approved for maintenance treatment for bipolar disorder with history of depression, not mania, not mixed phase, and not for any acute phase management. But it is indicated for seizure disorder management. So let's take a pause, look at this table. Just to briefly summarize, you can see for acute phase management, we have 3 medications, lithium, Depakote, and carbamazepine. Most of them, actually all 3, are indicated for manic phase management, acute manic phase management. Carbamazepine is also for acute mixed phase management, and lamotrigine is only for maintenance depression phase management. Okay, let's move on to our second section, which is CANMET and ISBD 2018 guidelines for these mood stabilizers. So CANMET is Canadian Network for Mood and Anxiety Treatments, and ISBD is International Society for Bipolar Disorders. They most recently published these guidelines in 2018 for each phase of bipolar 1 versus bipolar 2, and for acute and maintenance treatment. I have summarized them here very briefly. Let's start with lithium. According to CANMET and ISBD guidelines, lithium is first line for acute manic episode management. They have level of evidence 1, 2, and 3. 1 is considered higher, more, better, and level of evidence 3 is weaker compared to 1. And the second indication for lithium is first line for maintenance treatment of any mood episode. Very similar to FDA indications, but here they say any mood episode versus manic phase only. Depakote is first line, just like lithium, for acute manic episode management, and same level of evidence is 1 here. But they also says that Depakote is second line for bipolar 1 depression management. Level of evidence is 2. Very interesting. Regarding carbamazepine, it's not first line for anything, but it is second line for acute manic episode management. Lithium and Depakote are first line here, and carbamazepine is second line. And the other indication is for bipolar 1 depression management, but as a third line, and you can see the level of evidence goes down to 2 here. And our fourth medication, oxcarbazepine, is not first line, not second line, but third line for acute manic episode management, but in combination with either lithium or Depakote, and level of evidence was 3 here. So definitely FDA has no indication here for oxcarbazepine, and according to CANMET and ISBD, should not be first or second line, but third line in combination with lithium or Depakote. Moving on to lamotrigine, it is first line for bipolar 1 depression management, And level of evidence was 2 here. Very interesting. They did recommended lamotrigine also as adjunct treatment in their recommendation. But they don't recommend lamotrigine for manic episode management. And here level of evidence was 1. We all know it should not be used for manic episode management, primarily for depression, if anything, in bipolar disorder. So take a pause again, look at this table. You can see acute manic episode. Most of these medication, except definitely for lamotrigine, carries that indication. Lithium depakote first line, carbamazepine second line, oxcarbazepine third line. For bipolar 1 depression, lamotrigine is there on top. And interestingly, depakote as second line and carbamazepine as third line is still there. And I will highly recommend for our core subscribers to go over these chapters we have made for you. Here I have summarized CANMET and ISBD 2018 guidelines into bipolar mania, bipolar 1 depression management, and for maintenance treatment for bipolar 1 disorder. And then there's a chapter for bipolar 2 disorder management, which will include all these phases and maintenance treatment. But in addition to these guidelines, we have also summarized here British Association for Psychopharmacology 2016 guidelines and famous Florida Best Practice Guideline 2017 to 18 for bipolar depression, mania, and maintenance treatment. I have only summarized CANMET and ISBD guidelines. They are more recent. But definitely go ahead and read these chapters. They will definitely help. And for our listeners who are not course subscribers yet, the first chapter 10.1 is available for free preview. Please read and let me know if this is helpful. Moving to our next section, which is lab workup needed before initiating treatment. Beginning our session with lithium again. Most important lab work needed before initiating lithium is renal function test. Because we know there is a risk of kidney damage, risk of nephrogenic diabetes insipidus with chronic lithium use. So it's recommended to have a baseline serum creatinine and eGFR done, and then follow this labs every 6 monthly. I will recommend core subscriber to read our chapter on lithium-induced nephrogenic diabetes insipidus, which will cover underlying mechanism of action, risk factors, treatment, recommendations, guidelines, and topic like if this is reversible if you discontinue lithium. Next lab needed after renal function test is TSH, thyroid stimulating hormone, because of the risk of hypo and hyperthyroidism with chronic lithium use, although hypothyroidism is more prevalent. So it's recommended to have a baseline TSH level, and initially you can follow this level every 3 to 6 monthly, and if level remains in normal range, you can reduce the frequency to 6 to 12 monthly. And again, we have a chapter on this topic also. It's called lithium-induced hypothyroidism, which will talk about underlying mechanism, risk factors, monitoring, and treatment guidelines. Next lab after this is calcium level. Calcium is important because lithium also carry risk of hyperparathyroidism. So it's recommended to check calcium level at baseline and then at 6 months and then annually after that. And interestingly, we have a chapter on this also in our course. It's called Lithium and Risk of Hypercalcemia and Hyperparathyroidism, which will talk about underlying mechanism, what are the symptoms of hypercalcemia, what lab work is needed, and the monitoring that I just told you. And it will also tell you how to differentiate primary hyperparathyroidism from lithium associated hyperparathyroidism. After these basic three important lab, you need to do EKG in patient more than 50-year age. You need to do body mass index and lipid panel because of the risk of weight gain, and pregnancy test because we know there is a known risk of Epstein anomaly. We'll talk about that briefly moving forward. And as I said, in our course, we have these chapters from 2.23 to 2.26, which will talk about basic side effects, profile, management of lithium here. Moving to Depakote now. The first blood work needed with Depakote is complete blood count, CBC, because we know there is a risk of thrombocytopenia, pancytopenia with Depakote, although it is known to be reversible if you discontinue Depakote. But studies have shown that this risk increases with increased Depakote level, valproate levels. And one study showed if the levels are more than 110 in female and 135 microgram per ml in males, the risk increases. And they also recommend that a patient taking Depakote either plan for surgery or is pregnant. You need to monitor CBC with coagulation parameters. Next blood work after CBC is comprehensive metabolic panel, CMP, with main focus on liver function test because of the well-known risk of hepatotoxicity with Depakote. And it is also recommended to avoid Depakote in patients with history of hepatic porphyrias. And next blood work is lipid panel and monitoring patients' body mass index before you initiate this medication, and pregnancy test. Very important with all mood stabilizers. Pregnancy test. Depakote is known to carry risk of neural tube defects, oral cleft, and low IQ, so it should be avoided with pregnancy. Next medication is carbamazepine. First blood work is again CBC with focus on thrombocytopenia, but package insert also says possibly reticulocytes and serum iron. Please comment below if you do serum iron levels before initiating carbamazepine. Next blood work after CBC is CMP with main focus on liver function test to reduce the risk of hepatotoxicity. Third one is interesting. It's HLA-B star 1502 allele. It's not indicated for every patient, but it is indicated for patient at high risk of having this allele, because having this allele and taking carbamazepine will increase the risk of having Stevens-Johnson syndrome or toxic epidermal necrolysis. Serious condition, will need hospitalization. And which patients are at high risk? They say patients with Chinese ancestry. And one study also showed that more than 15% is seen in population living in Hong Kong, Thailand, Malaysia, and some parts of Philippines. Close to 10% is seen in patients living in Taiwan. Close to 4% is seen in patients living in China. And in South Asians, Indians, intermediate prevalence was seen in close to 2 to 4%. So be mindful of this population and worth doing this testing. We recently posted on our website. You can go and check. There is a topic where we published updated guidelines by International Society of Psychiatric Genetics. They published their guidelines also recently, and they included this testing for patients on carbamazepine and also for oxcarbazepine, I believe. Please read that. It's available for free on our website. Next blood work after this is pregnancy test. Carbamazepine is known to cause neural tube defects and should be avoided in pregnancy. Next medication is oxcarbazepine. Here you do CMP with main focus on sodium because of the risk of hyponatremia. Studies have shown that it can reduce sodium to less than 125, and the risk is high during first 3 months of treatment. But some studies have shown it even happening even after 1 year. So stay cautious when you prescribe this medication and monitor their sodium level closely. After that, you do pregnancy test like all mood stabilizers. And then last medication, lamotrigine. Basic blood work here is needed like CMP, pregnancy test, and others. So this is a brief summary of lab work needed with all these mood stabilizers. And again, I will recommend to our course subscribers, please read these chapters from 5.6 to 5.11. These are posted under Women's Mental Health section of our course. This will definitely help you get a brief summary of these effects of mood stabilizers during pregnancy and postpartum. You will see this chapter 5.6 on lithium is available for free preview for members who have not joined us yet. This chapter will summarize old studies done in 1970 which showed high estimated risk of Epstein anomaly with lithium. And this chapter will also summarize recent study which shows risk to be not that high. This will also show you what is the lithium placental passage if you use lithium, and what guidelines to be used if you prescribe lithium during late pregnancy. It will show you importance of monitoring lithium level and everything. So please read when you're free. Very important chapter. And also there is a PDF that you can download for free in the end of this chapter. Okay, let's move forward. This next section is regarding therapeutic level, and this is a short section. So let's begin with lithium first. Lithium therapeutic level indicated for acute management of mania is little on a higher side, which is 0.8 to 1.2, but once patient is stable, level indicated are between 0.6 to 1.0. Preferable to keep person on the lowest therapeutic level if possible, and ideal recommendation is to wait for 5 days before checking lithium level. Depakote. Therapeutic level is between 50 to 100 microgram per ml, In some cases, higher may be indicated based on therapeutic response. And as we discussed recently, higher level, more than 100, carries risk of side effect getting more, including risk of thrombocytopenia, pancytopenia, and ideal to wait 3 days for Depakote to reach therapeutic steady state before checking levels. Carbamazepine level, therapeutic level range is 4 to 12 microgram per ml. Oxcarbazepine, not able to find any range, but if anyone of you know the therapeutic range that you use in your clinical practice, please reply below. Lamotrigine, data for bipolar is not consistent, but there is good data for seizure disorder management. Level between 2.5 to 15 microgram per ml is considered therapeutic. Higher is not very helpful. Again, our core subscribers can read these chapters on therapeutic drug monitoring for lithium, valproate, and lamotrigine. This will tell our members importance of lamotrigine in pregnancy. Also, the chapter on valproate is very helpful. It will also discuss how to calculate Depakote level in patients with low albumin level, as that can impact total valproate level. Our next section is risk of drug interactions with individual mood stabilizers. Very clinically important topic. We'll begin with our favorite lithium again. So lithium level can increase with many commonly used medications for medical comorbidities. First and foremost is antihypertensive medications, including thiazide diuretics, ACE inhibitors, and angiotensin receptor blockers. And the second common class known to increase lithium level after antihypertensives is non-steroidal anti-inflammatory drugs like ibuprofen. So exceptions include aspirin and Solendac. And antibiotics including metronidazole and tetracycline carries risk of increasing lithium level. Important point is, since antibiotics are not indicated for long duration, but antihypertensive medications are, we should be mindful of this. And some medications can reduce lithium level, thereby affecting efficacy. And among these medications, there are antihypertensive medication class called osmotic diuretic, including mannitol, and theophylline or aminophylline. So importance of knowing this class. Next medication, Depakote. There are more medications known to decrease Depakote level than increase it. There's only one medication known to increase Depakote level, and the medication is aspirin. It's very important when somebody is taking aspirin with Depakote, measure free valproate level rather than total valproate level, because total valproate level may not give you accurate levels. Aspirin is known to increase free valproate level by almost 4 times. Next is medications likely to reduce or decrease Depakote level. And first well-known medication is carbamazepine, which we all know is a pan-inducer, can reduce many medications level getting metabolized through cytochrome P450 system. And similarly, phenytoin and rifampin carry the risk. And among antibiotics, carbapenem antibiotics, and more important than that is estrogen containing hormonal contraceptives. They can reduce Depakote level and they can also reduce lamotrigine level. So we'll talk about that. And very important relationship between Depakote and lamotrigine. Clinically important topic again. Whenever a person is on Depakote and lamotrigine together, this combination can result in reduction in Depakote level and increase in lamotrigine level, which carries two risks. First, Depakote is low, patient is not getting efficacious dose of Depakote, and second, lamotrigine is high, so that risk of Stevens-Johnson syndrome and other side effect profile increases. So they recommend reducing the frequency of Depakote and lamotrigine. Lamotrigine dosing titration is lowered when a person is on combination of Depakote and lamotrigine. Moving forward to next medication, carbamazepine. Medications that can increase level of carbamazepine first are antidepressants, including fluoxetine, fluvoxamine, and trazodone. Then cimetidine can increase the levels. Olanzapine carries the risk. And among antibiotics, ciprofloxacin, macrolides, erythromycin, and azoles. Class of antibiotics can increase that. And there are some medications that can reduce the levels, well-known phenytoin and rifampin. And we already talked about this, but we should be mindful of this fact that carbamazepine is a pan-inducer of many cytochrome P450 enzyme system, and it's also known to auto-induce its own metabolism, thereby after some time it can reduce its own level also. So importance of monitoring carbamazepine level during entire course of treatment. Next medication is oxcarbazepine. Not known any specific medication that can increase its level, but again, same medications can reduce the levels, which are carbamazepine, phenytoin, and rifampin. And an important clinical interaction of oxcarbazepine is with oral contraceptives. Oxcarbazepine can decrease the oral contraceptives, thereby reducing their effectiveness. So importance of having patient educated on this and having alternative contraceptive options discussed. Next is regarding lamotrigine. Level can be increased with Depakote that we already talked about, and it can be decreased by same medication that we talked about, which are carbamazepine and rifampin, and oral contraceptives can reduce lamotrigine levels. Then there are antivirals like lopinavir, ritonavir, they can reduce it. So let's take a pause, look at this table again, very clinically relevant table. Here I will just summarize one more point again, regarding oral contraceptives. Oral contraceptives can reduce Depakote level and lamotrigine level. And on the other hand, oxcarbazepine can decrease oral contraceptives levels. And our last section for this topic is just compilation of various clinical facts regarding these mood stabilizers. I will try to summarize them quickly. Let's start with lithium. First clinical fact about lithium is it's preferable to use less frequent dosing. Many studies have shown that if you use once a daily dosing over twice or thrice daily dosing, it's preferable or safer from renal standpoint. Second clinical fact is risk of toxicity increases after 1.5, but I will be cautious when level starts to go beyond 1.0. Lithium have well-known anti-suicidal benefit. The other medication known to have this benefit is clozapine. And lithium is also used as an augmentation agent for treatment-resistant depression management. And last clinical fact that we already talked about is risk of Epstein anomaly with lithium. Again, we'll recommend reading that chapter. Very helpful. Next, Depakote. First clinical fact is Depakote is preferred for rapid cycling type of bipolar disorder over lithium. And Depakote have well-known risk of hair loss. Many patients report that. We did have a chapter on this topic here in our course. This will talk about underlying mechanism of hair loss from Depakote and what treatment can be used. Mostly zinc, selenium, and biotin combination is known to be effective. Next fact is there is risk of pancreatitis, which can be life-threatening, and risk of polycystic ovarian syndrome. So ideally avoided in females, young females. The other reason is teratogenic risk. We talked about it. Neural tube defect risk is higher, so avoid this in pregnancy. Regarding dosing for Depakote, you initiate at 10 to 15 milligram per kilogram. Highest you can go is 60 milligram per kilogram per day dose, but going beyond that level is not known to be beneficial. Regarding carbamazepine, we already talked about this. Avoid in patients with this allele, HLA-B1502. Risk of SIADH, syndrome of inappropriate ADH secretion. Again, it's not recommended in pregnancy. It can do false positive result for tricyclic antidepressant. I think it's more good for exam purposes. And carbamazepine is known to have decreased risk of weight gain compared to lithium and Depakote. Next medication, oxcarbazepine, similar risk with HLA B1502 carrying allele. It's mostly off-label use for bipolar. We talked about this initially at the beginning of this lecture. There is decreased risk of drug interaction. We talked about this also. And they say there is decreased risk of overall side effects compared to carbamazepine. And again, not indicated for pregnancy. Last medication is lamotrigine. Rash. very important to differentiate benign rash from Stevens-Johnson syndrome rash. We have a chapter on this also. I will recommend core subscribers please read chapter 2.27, where we describes different grades of rash from lamotrigine, timeline for onset of this, differentiating benign from lamotrigine rash, and recommended treatment. Next clinical fact with lamotrigine is, we already talked about this, that with Depakote you need to do slow titration because that will increase lamotrigine level, thereby increasing the risk. Next clinical fact with lamotrigine is, if you miss lamotrigine for more than 5 half-lives, you have to start from the starting dose of 25 with slow titration on a weekly basis or 5 to 7 day basis. And we have a chapter on that also. So these are the chapters that I was talking about. Chapter 2.27 talks about lamotrigine associated rash. Chapter 3.9 will talk about risk of interaction between lamotrigine and anticonvulsant and how to titrate these medications. This includes Depakote and other anticonvulsants. And chapter 10.16 will talk about when to restart lamotrigine after abrupt discontinuation. So this ends our chapter. Thank you, everyone. Please do not hesitate in contacting me if you have any question, and please reply below if you have any questions. Thank you again. Take care. Bye.